Hello, good afternoon, everyone, and thank you for coming back for the final event of the 2020 PNHP annual convention. So just a quick thank you, first of all, to everyone who donated during our last session. I'm told that we raised $23,000 so far, and that's critical funds for us to continue our operations, to continue our office operations. And so I really thank you and for your generosity. So I want to go ahead and introduce our final speaker, our keynote speaker. So it is my pleasure to introduce to you Dr. Rhea Boyd, who wears a pediatrician, public health advocate, and scholar who wears many hats. So Dr. Boyd writes and teaches on the relationship between structural racism, inequity, and health. And she has a particular focus on the child and public health impacts of harmful policing practices and policies. She also serves as the chief medical officer at San Diego 211, which connects San Diegans impacted by chronic illness and poverty to services that they require. Dr. Boyd also serves as Director of Equity and Justice for the California Children's Trust, an initiative designed to advance mental health access to children and youth across California. So Dr. Boyd, you have the floor. You can thank you so much for joining us, and I'm really looking forward to your presentation.
Thank you so much for having me. I'm so excited to be here today. I told Adam earlier, I woke up today excited about this presentation. Okay, give me 1 second. I'm just going to share my screen so we can all look together. Let me make that smaller. Okay, so today we're going to talk about the pandemic. I know we've been talking about the pandemic a lot, but I'm going to tell a particular story about the pandemic that describes it as a syndemic, where the epidemic of policing is actually contributing to the morbidity and mortality we're seeing emerge amid the pandemic. So we're specifically going to focus on racism as a form of violence that threatens and really shortens Black lives, but all of our lives in the United States. I left my Twitter handle on this page, and I think they put it into the chat too. Sometimes at the end of these, we don't get time to talk about all the things people are interested in, or folks want more links to the references. So please just hit me up on Twitter. I'm there probably more than I should be. I don't have any disclosures today. So let's jump in. If we're going to talk about what are the forces that are driving this pandemic, we can't ignore the fact that we live in a country with enormous inequality and an inequality gap that's widening. My home state of California leads the way, but across the country, the top 1% of earners holds more wealth than the bottom 80% combined. Part of that is because wage stagnation is profound in this country. If you compare the hourly earnings for non-supervisory employees, folks who work but are not the boss, what we see is that last year they were earning essentially the exact same that they earned in 1973, half a century ago. And so the result of that is the purchasing power of our workforce has barely budged in 50 years. And so now we have to confront the reality that we're a part of a generation for whom only half of our children will out-earn their parents. Again, this is an aberration over the last half century. But we also know that intergenerational economic mobility is profoundly shaped by race and gender in this country. This is data by researcher Raj Chetty, who used to be in California at Stanford, but is now at Harvard from his Opportunity Insights Labs. What it shows, if you look at the green map on the right, is that it essentially pays to be a little white boy who grows up to be a white man in the United States, because no matter where he lives, he is likely to earn more in adulthood than his parents did when he was a child. Conversely, if you look on the left at that red and orange map, what you see is that there is really nowhere safe to be a little Black boy who grows up to be a Black man in this country, because virtually everywhere he lives, he is likely to earn less in adulthood than his parents did when he was a child. As Chetty and colleagues summarized, in 99% of neighborhoods across the United States, Black boys will earn less in adulthood than white boys, despite growing up in remarkably similar families. And this is what's so fascinating about this data. When I present it, people often say, well, it's not surprising that white boys fare differently than Black boys because we know this country's history of racism. And yet, these are two extremely similar little boys. They both grew up in households with two parents. Both of their households have comparable incomes. It's not the racial wage gap. They have comparable levels of education. It's not the racial achievement gap. They have comparable levels of wealth. This gap in mobility is not driven by the racial wealth gap. And they live on the same city block and go to the exact same school. It's not just residential segregation, which is a major driver of racial health inequities in this country. So what is it? What they found is that intergenerational economic mobility gaps are the smallest in areas where there's low racial bias among whites, where white folks are less racist, and where there's high father presence in Black neighborhoods. Now, this isn't father presence in your home. This is the presence of fathers on your city block. And so we have to ask ourselves, what's the relationship between white folks' racism and even casual forms of white racism, like white collar crime, as the Root journalist Michael Harriot refers to it, collar being spelled Caller, and father presence in Black neighborhoods. What happens when white folks call the police on Black folks just for existing in public is not only that it invites violence, intimidation, and potentially arrest into the life of that individual. If that individual is a father in that community and they're extracted from that community because they die as a result of that encounter, they have a prolonged hospitalization or disability as a result of that encounter, or they're incarcerated as a result of that encounter, it not only shapes their health and well-being, but the future economic mobility of the children, and particularly the little Black boys who live in that community as well. So this is how we have to start thinking about the intersections between state-sanctioned violence and the health and economic mobility of children in this country. So this is the pre-existing inequality that already existed in the United States before COVID-19 even broached our shores. And I simply enlarged that map of the mobility gaps for Black boys. But if you overlay, this is a map just from this morning from the New York Times of current COVID outbreaks. If you overlay it, you see it aligns closely to areas where intergenerational mobility is shaped by race and gender in this country. And so what we've seen from COVID is that we know that Black, Latinx, and certain Asian subpopulations have the highest risk of COVID hospitalization and death. And much of the data that we have around racial health inequities has kind of focused on the adult population in this way. This is data from the Kaiser Family Foundation that looked at 50 million patients in EPIC. What we also see, I'm a pediatrician, is that these inequities also exist for children. Children are not immune from the same ways that racism affects everyone's health. And so this is looking at hospitalization rates by race for children who are under 18. This is data from the CDC's Morbidity and Mortality Weekly Report. And what we see is that Black and Latinx children, youth, and adolescents make up to 75% of COVID hospitalizations. Similarly, we see an overrepresentation of Black and Latinx youth among youth who suffer COVID-related deaths. This, again, is from the CDC's Morbidity and Mortality Report, and it shows that 74% of COVID-related deaths for young folks under age 21 are either Black or Latinx. Again, looking back at adults, what we see over time is that those inequities are widening. Instead of us recognizing that these inequities emerged in April and us doing something about them such that they narrowed, they are widening over time. This is data from APM Research Labs. And what you see is that that top curve is Black Americans who have the highest COVID mortality rate, approximately 3.2 times that of white Americans. What you'll see in that yellow line underneath is that Indigenous populations have the second highest COVID mortality rate across this country. But if you look in particular states like Mississippi for Choctaw Nation, or Utah, New Mexico, or Arizona for Navajo Nation, Indigenous populations in those areas have the highest COVID mortality rate. I also want to draw attention to this third line, that light blue line, that's Pacific Islanders. I think Pacific Islanders have gotten lost in our national conversation about COVID mortality rates and COVID and the uneven racial burden of COVID across this country, but they have the third highest COVID mortality rate. And here in my home state of California, we're increasingly concerned about those inequities as well. And so we have to ask ourselves, are these just disparities or are these inequities? And I tossed this slide in there for the students in the room. So disparities just describe differences in health for populations, but inequities are those differences for populations in their health outcomes that are completely preventable. And because they're preventable, they're unjust. We today are talking about the gaps from COVID that are truly inequities. And so we should refer to them as inequities, as I've been doing. And so we should talk about where those come from. Health inequities arise when certain populations are made vulnerable. And I put that in red and in bold to remind us that no racial group is innately, biologically, or genetically more vulnerable to diseases like COVID-19 than any other. They're made vulnerable. And that often happens through the inequitable distribution of protections to keep folks from getting sick, and the inequitable distribution of supports to treat sickness and ameliorate all of the adverse consequences of being sick, like the economic burden we've seen accompanying the pandemic. And so even as we talk about the pandemic, we continue to focus on these risk factors, like chronic underlying illness like heart disease or hypertension, elevated age, somebody who's elderly, or poverty as major drivers for COVID morbidity and mortality. But when we do that, we miss the context. We miss the fact that segregation profoundly shapes the racial distribution of heart disease in this country. We miss that discrimination and chronic exposures to discrimination increases rates of hypertension in communities of color, and particularly for Black Americans. We miss that environmental racism literally shapes who breathes in clean air and who breathes in toxins, and thus shapes the racial distribution of asthma in our communities. We miss that the racial wealth gap profoundly concentrates poverty within communities of color. And toxic stress and early exposures to childhood adversity can raise one's allostatic load over one's lifetime, such that you have increased exposure to cortisol in your body and more wear and tear on your organ systems, which slowly weathers your cells. Weathering is that process that then silently ages your cells, such that a person's chronological age could actually be less than their cellular age, so that they suffer complications and early death at much younger ages than expected. These are all examples of how structural racism has profoundly shaped the racial distribution of COVID-19 in this country. Or to use the words of my favorite pediatrician, Kamara Jones, it shows how inherited disadvantage, not just inherited disease, is shaping the racial distribution of this pandemic. Taken together, it illustrates how both the physical, but also the structural, the legal, the normative environment in which we're all growing, working, learning, and playing is not only shaping our health, but the health of our children and our children's children. So when we name racism as a cause of health inequities, it's important that we name a mechanism, and we're going to go over just one to make that point. So we know that hand washing is probably the simplest, the cheapest, and the oldest way to prevent the spread of infectious disease. And yet race, not income, is the single greatest predictor of who has access to clean water in this country. Black American and Latinx populations are twice as likely to lack access to clean water in their homes as white households. And Indigenous populations are 19 times as likely to lack access to clean water in their homes as white households. Here, structural racism is operating through residential segregation and then public divestment in Indigenous, Latinx, and Black communities, which is excluding them from access to one of the simplest and cheapest forms of infectious disease prevention. And so we should also understand that the distribution of clean water in this country is what shapes the racial distribution of illnesses like COVID-19. So when we talk about the inequitable risk of COVID, we can't simply use words like poverty or underlying illness to describe that risk. And I put a star by risk to just remind us that we're thinking at the population level about systematic drivers of outcomes for groups, not at the individual level where an individual's behavior might drive their health outcomes. At the population level, the risk factors for COVID are legacies and current practices of racial exclusion, discrimination, disinvestment, and violence that concentrates disadvantage within communities of color, creates adversity for children of color that affects them across their life course, and shapes the population level opportunity to be well, and provides the perfect conditions for folks who live in communities of color to be sick. These factors are why the all-cause mortality is increasing in this country. Back in 2015, there was a large focus on the rising all-cause mortality of white Americans. But what you see from this paper in JAMA that came out just last year is that the highest all-cause mortality in this country is actually from non-Hispanic Black folks and non-Hispanic Indigenous populations who have the highest all-cause mortality. Taken together, because the mortality rate is increasing in this country for these groups at such an alarming rate, life expectancy is decreasing in the United States, and it's been decreasing since 2014. This is an aberration for any wealthy nation in the world, but especially for the country that spends more money on healthcare than any other. And so, despite being in the middle of a deadly pandemic where COVID-19 is now the third leading cause of death for 2020, white mortality is still projected to be less than what Black Americans have experienced every year pre-pandemic. This is a chart that adapted data from researcher Elizabeth Wrigley Field that was in the New York Times. And what it shows on that dotted line is that alarming jump in white mortality from the pandemic. But then what you see is that chasm between the alarming jump in white mortality and what Black Americans have experienced every year at baseline. We have to note that this chart doesn't even include Black mortality from COVID-19, which we've covered is the highest COVID-19 mortality rate in the country. It doesn't cover Indigenous mortality, populations who have the highest all-cause mortality in the country. It doesn't cover Latinx mortality or Pacific Islander mortality, all of whom is likely also above that line projected for white folks. And so, as Elizabeth Wrigley Field summarized, racial inequality is as deadly as COVID-19 in this country, because despite us being in the middle of the most deadly pandemic our nation has seen in a century, white life expectancy will still remain higher than Black life expectancy has ever been. And so we have to start to interrogate that legacy. We have to say, what is that history and what are those practices that have brought us to this moment? When we do that, we often go back to this time, to the Jim Crow South and segregated public accommodations like water fountains as pictured here. But we don't as often go back to this time. This is a picture from Newark, New Jersey in 1967 and what historians refer to as the long hot summer of 1967. Historians call it the long hot summer because during that summer, there were 159 race massacres across the United States, all sparked by an event of police violence against a Black taxi driver in Newark, New Jersey. When we talk about the mortality and morbidity gaps between racial and ethnic groups in this country that exist, we rarely trace its origins back to moments like this and back to little Black boys like this, who are walking down your own city block with your own government at your back. That's the National Guard who was called in, and their guns are drawn and your hands are up because you don't feel safe. We don't talk about what it's like to be these Black women who line the sidewalk, who are not intervening, some of whom also have their hands up because they don't feel safe. Or what it's like to be these little Black boys on the left side of the photo who are looking back at a boy who's perhaps just a little bit older than they are, who are learning something about what it means to be Black and a boy for their future in this country. We don't talk about how state-sanctioned violence has absolutely shaped the underlying distribution of chronic illness in this country and thus driven morbidity and mortality during the pandemic. And we don't talk about how little has changed. This is a Pulitzer Prize-winning photo that covered Time magazine in 2015 after police murdered Freddie Gray in Baltimore. It was taken by photographer Devin Allen. And they asked that apt question back then: how far have we come? We continue to ask that question in 2020. And so when we're talking about those factors that are contributing to that uneven racial distribution of COVID-19, we absolutely have to be talking about police violence. So what do we know about police violence? We know about 1,000 people are killed by police every year in this country. But we know it's a particularly deadly exposure for Black men and boys, of whom the National Academy of Sciences told us just last year, 1 in 1,000 will be killed by police in their lifetime. I always share this figure when I'm talking to other pediatricians and people who care for kids, because 1 in 1,000 is also the mortality rate of measles. When you think about the near constant public health surveillance and investment we as a society have placed in eradicating measles because we deem it that deadly. And you compare it to the relative little to nothing we have done as a healthcare infrastructure and as public health advocates to eradicate police violence. You see the ways that racism not only shapes deadly exposures in this country, but it also shapes our responses in healthcare or our lack of response. As Kamara Jones is often quoted, structural racism sometimes shows up as inaction in the face of need. And that absolutely has been our response in healthcare. That's a problem because we also know that police violence is a form of community violence. It's a form of gun violence. And we have an infrastructure that advocates against community violence and tries to address gun violence in a way that we don't do around police violence. But it matters. This is data from researcher Ali Silwell, who taught us that for folks who live in neighborhoods where police kill unarmed civilians, and this is particularly true for Black folks and for Latinx populations, they have higher rates of hypertension and obesity. She also found associations between living in neighborhoods where police kill unarmed civilians and asthma and diabetes. So think back again to those underlying risk factors that we are saying contribute to COVID-19. Just living in a neighborhood where police kill folks drives risk for some of those chronic conditions. And it particularly does so for women, who I think when we talk about police violence, we often center our narrative around the impact on men. But we must understand that women are both direct victims of police violence, Sandra Bland, Breonna Taylor, right? And they are indirect victims of the spillover events of living in neighborhoods that are lethally surveilled, which is a term, again, from Ali Silwell. We also have to acknowledge that some folks' exposure to policing is shaped by their immigration status. And a study just from a couple of years ago that looked at 554 women born in Mexico found that worrying about deportation drove their risk for obesity. It was associated with higher pulse pressures and higher systolic blood pressures. So again, we have to think, how does policing contribute to the underlying morbidity, that then exacerbates the morbidity and mortality we're seeing in this pandemic? That is true for folks who are exposed to their municipal or local police departments, and it's true for folks who are exposed to federal policing like ICE. We also have to acknowledge that some kids are exposed to police in their learning environments. Across the US, almost 1 out of every 3 students goes to a public school that employs a police officer, but has no psychologist, no nurse, no social worker, and no counselor. We have to think about what our collective investments are in and how that illustrates our values in this country, and who then is rendered more vulnerable by those investments. As healthcare practitioners, we also have to own the fact that we can sometimes extend the carceral gaze into the lives of families by reporting them in our role as mandated reporters to Child Protective Services. We know that there are racial inequities in who is reported to Child Protective Services, and that those reports often render already marginalized families and populations hypervisible to the state in ways that increase their marginality. We know that happens because data from the American Public Health Association told us just a couple of years ago that by the time Black kids reach 18 years old, 1 out of every 2 would have been referred to CPS. Now, it goes without saying, but I'll just say it to underscore the point. Black families are no more likely to mistreat or abuse their children than any other. And yet we see a preponderance of CPS referrals for Black families, which is also a form of surveillance that increases the carceral gaze in their lives and threatens removing children from their families, which again is a major source of childhood adversity and toxic stress. And so for some youth, they need not even be present to directly witness with their own eyes a police encounter to have it impact their lifelong health. For some, they will experience it as the absence of their caregiver or a transition in custody. Or for some, as we saw in that photo from Newark, it could feel like the criminalization of themselves or their peers. And it's those exposures that then link even routine police encounters with events that can be associated with loss or stress. And that's how it then comes to shape youth health over their life course. Ultimately, the violence of policing separates kids from the social networks on which they rely and in which they thrive. and the violence of racism and the many structural inequalities that racism creates at a population level ultimately impairs and disappears or takes away children's caregivers. That's why racism is a critical root of childhood adversity, which then can create toxic stress and increase an individual's allostatic load and weather their cells. So racism then becomes a devastating root of chronic undertreated disease and completely preventable premature death in this country. And the pandemic and the syndemic with police violence, I think, is an excellent illustration of that. In short, racism kills people. But we know that equality can save folks' lives. Equal access to resources and rights and power saves people's lives, right? It's how you get equal access to healthcare. It's how equal access to rights like voting allows you to advocate for your community in a way that you can't if you don't have the franchise. And so that is why early in this pandemic and early in the national uprising, colleagues and I were quoted in Time magazine saying, protest is a powerful and vital public health intervention. Because the history of protest in this country is that protests, particularly by folks of color and Black communities in particular, have extended that access to equality. They've extended equal rights. They've extended the right to equal resources to groups that were previously denied. And doing that increases populations, improves, I'll say, a population's health outcomes. And yet, not everyone's protesting for the same thing in this country. And this is something that we have to come to confront. So this is a picture taken from the Texas State House lawn on June 30th, which at that time they had had a record number of cases and the governor closed bars. But Texas wasn't alone. Predominantly white protesters took to State House lawns across the country to protest public health advisements. And many of us in healthcare and in public health looked on and were confused. And so I think we also have to question the ways that whiteness can work to also engender racism at a population level that also harms the health of white folks too. So we're going to talk a bit about whiteness for a moment. Too often, whiteness is normative. It's shaping everyone's access to power and resources, but we don't name it. And we especially don't name it in healthcare. And so I want to name it for us so that you can use this in your work going forward. So what is whiteness? First, it's different than white. White is a racial status based on someone's perceived skin tone. Whiteness is the structural apparatus that then confers certain privileges and advantages on folks who align with that racial status, such that they, through laws and norms, can be empowered, normalized, favored, and rewarded as a population. I use this figure of someone getting a boost over a wall to describe how whiteness works, because it's not to say that individual white folks don't face hardships. They absolutely do. And those hardships shape their health and well-being just like any other population. And yet, whiteness can be the boost individual white folks need as a part of a population above those hardships. I'll give you two examples. One, we know that when compared to white populations, Black populations have less wealth at every level of income. Or when compared to white populations, Black populations have less opportunities for employment at every level of education. These are examples of how whiteness can be that boost for individual white folks above their income level or above their education level for access to wealth and employment in ways that other racial and ethnic populations, particularly Black folks in this country, are not afforded. And so we have to think about how that boost creates and drives the racial health inequities that we talk about throughout this presentation. But we also have to confront the ways that those advantages can sometimes portend disadvantages. This is the central argument of this book by Dr. Jonathan Metzl, who is a psychiatrist at Vanderbilt School of Medicine, and it came out just last year. In full disclosure, I reviewed this book for The Lancet in January of this year, but I share it here because I think his analysis is urgent and compelling. Essentially what he says is that when white folks invest politically in the idea that they should have exclusive access to rights and resources that other people don't have, that can in some ways shrink the pot of resources available to everybody. For example, if one way that white folks invest in their whiteness is to say, well, I don't want my children going to their public school with immigrants or with non-white students of whatever background, so I don't want to pay for our tax dollars to pay for public schools, that not only hurts the populations who rely on public schools, it hurts everyone. I think we see the same thing happening during the pandemic. If folks want the exclusive rights that come with being white to mean that they have that they are not beholden to the same public health advisements that the rest of us are beholden to, that not only hurts the folks who are around them, that renders them more vulnerable as well. And so we have to confront the ways that whiteness, driven in many ways by white supremacy, also harms the health of white folks. Because if we talk about the burden of morbidity and mortality of the pandemic, we have to acknowledge the fact that while there are enormous gaps in the rates of COVID mortality and morbidity, in absolute numbers, white folks have suffered an enormous amount during this pandemic. And so we have to question why some white folks, in the face of such morbidity and mortality, would respond by decrying public health advisements instead of trying to participate in things that keep everyone healthy and well. And so to adequately respond at scale to racism as the public health crisis that it is for folks of color and for white folks, we have to name racism as a driver of racial health inequities. We have to then identify how it works, and we have to eliminate racism. So we're going to go through some ways we can do that to close. We are not doing well at naming racism. This is a systematic review from 2018 that just looked at our public health literature over the last decade or so. And what they found is that over that decade, only about 25 articles actually named institutional racism in the abstract. And this was looking specifically at our 50 highest impact journals. But what's more, of those 25 articles, only 16 had institutional racism as a core concept. Just since the beginning of this pandemic, that has changed. I think many of us have seen journals try to take responsibility for their lack of engagement with racism as a fundamental driver of disease and racial health inequities, which is good. But once we name racism, it's then critical to identify the mechanism by which it works, which I attempted to model for you in this presentation. The problem is, if you don't identify the mechanism by which it works, too often our research and our clinical practice then reverts to these insidious forms of patient blame. One of the most common and accepted manifestations of patient blame is the undue focus we have in our field on patient mistrust as a potential driver of racial health inequities. If folks are interested in this topic, I could riff on this all day, but for brevity, I'll just refer to an article that colleagues and I wrote in Health Affairs blog earlier this year. What we said is that while patient trust absolutely drives healthcare use behaviors and is an important part of the patient-physician relationship, incessant racial health inequities, the fact that racial health inequities persist, are not about what patients have failed to feel. It is not because patients don't have trust in us that they suffer worse health outcomes. It's because of what our systems have failed to do for people. And that is critical to understand. So to be clear, patient trust will never, and please quote me on this, it will never solve racial health inequities or narrow gaps in outcomes. Eliminating racism does that. People suffer adverse health outcomes, and we see these gaps because they are made vulnerable by forms of structural racism, just like we've identified. And the pathway to address that isn't to ask people to trust us, especially not during this deadly pandemic. It's to make sure that we are treating people with dignity and equitably and responding to the ways that racism has harmed them within our systems and within society more broadly. And so to eliminate racism, we as a field have to contend with and move towards abolition. So this is a schematic I think we often see used when we talk about what abolition could look like in healthcare, right? We start with this fence metaphor and the baseball game, and we say we could provide kind of equality, or a universal intervention. And I know this is positions for a national healthcare program, so we'll toss out that the universal intervention could be something like universal healthcare, which I'm a huge proponent of, right? But, oops, sorry, we're going out of order. Let's just bring all these to the forefront. We'll go now to the equity. Instead of equality, right, equity is now in vogue. And what we're saying is that even with universal healthcare, some folks are going to face barriers to receiving that care, right? So one way that we could address that right now is to target populations affected by segregation, because segregation drives some of the resource inequities that then inform the racial distribution of COVID. And so, for example, you could give universal testing, but in communities affected by segregation. And that might be a more equitable approach. But then liberation, or getting closer towards abolition, acknowledges that you got to get rid of that fence, right? That there's a barrier such that folks are still being disproportionately exposed to COVID. So to again extend this metaphor, we could talk about mandated worker protections, things that will protect people as they move through the world to ensure they have adequate access to paid sick leave and PPE in their work environment, or hazard pay, such that they are not disproportionately exposed to COVID. If we were going to say what the next leading edge is, one thing that I've been talking more about that if folks are interested in, I think we could have a discussion about today, is love. We are in the middle of a pandemic where our healthcare workforce has a shortage of PPE. And I think what love would look like as a part of our care system is sharing that PPE, despite our shortage, with other healthcare workforces that don't have equal access. Because we know essential workers are predominantly folks and mostly women of color. And we know our workforce is predominantly white. And so sharing PPE would also be a profound anti-racist intervention. And love, ultimately, I think, has to become the metric by which we measure our system's performance, right? So this is the schematic that we often see. But just last week, I read this incredible paper, first authored by Nicholas Barcelo, that gave us a different formulation to consider that baseball metaphor, which is that it never was an even playing field to begin with, right? We as a field have to confront the ways that inequality is actually manufactured, it is created, and that we sometimes perpetuate it by even just ignoring it. Ignoring the fact that the reason some people can't see over that fence isn't because they're innately innately short. It's because they are held down. They're in a hole. They're starting from way behind the line. Or mass incarceration, right, is affecting their ability to move freely in the world. And so we then have to confront those forces. And that's why I say we have to think about abolition, because if we don't confront those forces, there will be no even leveling of the playing field, even with something like universal healthcare. And so how do we confront those forces? One way could be to redistribute wealth. We've talked about that economic mobility gap, so we can confront that by redistributing wealth. Because we know for every dollar of wealth held by a household with white children, households with Black children have a single penny. Again, to reinforce this idea, we can't then just have a universal redistribution of wealth. And so this is a quote from the Roosevelt Institute that talked about even progressive economic agendas like raising the minimum wage. Am I a proponent of raising the minimum wage? Absolutely. Will that benefit Black folks and other communities affected by structural racism? Absolutely. And yet, it will not change the fact that a dollar of income in Black hands buys less safety, less health, less wealth, and less education than a dollar in white hands. We also have to abolish the ways that inequality continues to shape who really has an effective use of resources. So part of what that means is we have to own the ways that some of those forms of oppression live within our house in medicine. I have been calling over the course of this pandemic for police-free hospitals. As much as we want to talk about what police do when they're in the communities, as healthcare practitioners, we first have to own what they do in our own institutions. This is a proposal from our county hospital here in San Francisco that is doing some incredible work to talk about how they can divest from the local police department that our county health system pays to staff our emergency rooms and be security in our hospitals, and instead invest that money in de-escalation training for staff and in the social and emotional supports that keep patients and staff safe when they come to our hospitals. We have to invest in police-free schools. We've talked about the fact that kids are still exposed to police in their schools. And for folks who are interested in this, I leave at the bottom of the slide, and I'll share these slides with the organizers so they can send them out, some references for folks who want a toolkit for how you can pursue police-free schools in your area, including a shout out to our Oakland Unified, which just because of the George Floyd resolution brought by the Black Organizing Project, severed their relationship with the Oakland Police Department. The reason we need to talk about police-free hospitals and police-free schools is because of the words here of Professor Leah Wright-Rigueur. She said this when I was on a podcast with her earlier this year, and it has stuck with me ever since. And it's something that I want us to take up in healthcare, which is that Black folks, and this is true of many populations, but I want to center Black folks here. Black people in the United States live without sanctuary. And colleagues and I in the New England Journal added to that. Black folks live without sanctuary from the intersecting forms of violence that threaten and shorten their lives, right? Black folks aren't safe on city blocks where white collar crime could have you engaging with the police simply for trying to barbecue at a park, right? Black folks aren't safe from police violence even when they sleep in their beds at night. Breonna Taylor is a devastating reminder of that. Black folks aren't safe when they go into school. 50% of kids go to a public school across the country that employs police officers, which are sometimes called school resource officers or SROs. Black folks aren't safe when they come into our medical facilities where armed local law enforcement is just a phone call away from their bedside. And some patients who are incarcerated at the time of their medical care are sometimes shackled throughout their visit. There is nowhere where Black folks can go to be safe from the harms of state-sanctioned violence and from racism more broadly. And so I want us to think about what it means to offer sanctuary individually as a provider, such that nobody receives any harm when they are with you individually, but also institutionally, so that we affirm that when patients seek our care or when our children seek to learn, that they will not be subject to the surveillance and harms of policing. Some of that means that we need to shift funding. This is a paper that just came out by Paul Fleming from University of Michigan that I just absolutely adored, where he and colleagues outlined the ways that we as a society invest in competing priorities. Just to give one example, they tallied up the cost per year of policing, the court systems, operating prisons, jails, parole, and probation to $181 million. Just think of what we could be doing as a society with $181 million were we not investing it in these punitive forms of policing. Similarly, just think about the investments that we have in trying to address all of the adverse health outcomes that come from these settings, right? Part of investing in a care economy absolutely requires divesting from punitive forms of policing. And so I also leave a link to community-based organizations like Care Not Cops from Portland or Critical Resistance, who has an 8 to Abolition framework for ways that we can do that. Finally, we also have to confront whiteness. This is the summary of the Kerner Commission report, which I encourage everyone who is not familiar with it to look into. The Kerner Commission was established by President Lyndon B. Johnson in 1967, following that long, hot summer. It had 10 members, 8 of whom were white men. And this was the 60s. And the conclusion that they reached about why there was an uprising across the country is alarming and remains relevant. What they said is, our basic conclusion is our nation is moving towards 2 societies, one Black, one white, separate and unequal. But this deepening racial division is not inevitable. The movement apart can be reversed. Choice is still possible. But what white Americans have never fully understood, and what Black Americans can never forget, is that white society is deeply implicated in the material conditions that drive the racial health inequities we've talked about today. White institutions created those material conditions. White institutions maintain them. And white society condones the health inequities that exist on the other side of those unequal material conditions. We have to confront the ways that whiteness has led our country to be deeply unequal and the ways that that is hurting not only folks of color, but white folks as well. The way to move forward is relationship-centered healing, because how racism works is that it separates us. It separates kids from their caregivers, often as a result of policing or the carceral state in their lives. It separates communities. Gentrification and displacement separates and scatters communities, and all of that inequality falls heavily on the relationships that are so precious to all of our health and well-being. And so the best way for us to also consider how we confront racism is to consider what health interventions we have that actually strengthen relationships between families, between communities, and between all of us across our different backgrounds and racial and ethnic affiliations. Ultimately, we have to move to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and too often hides. The future health and well-being of our kids and our kids' kids is absolutely going to be measured by how well we succeed in this. So thank you again so much for having me. I am eager to hear all of your questions.
Well, Dr. Boyd, thank you so much. I can certainly speak for myself, but I imagine it's an opinion shared by everyone on this call. That was a informative, powerful, provocative, thoughtful talk, and I really appreciate all of your perspectives. Thank you again for that. And I'm sure there would be a round of applause right now if that was something we could provide. Oh, here we go. There is a poll for the audience, but thank you again.
Thank you.
So maybe I'll kick it off. Just sort of just for the audience, please. I think the comments are disabled, but the Q&A function is not. So if you type your question there, I will be able to see it, and I'll be able to transmit the questions. I can tell you, Dr. Boyd, there's just a lot of superlatives in terms of superb, beautiful presentation. So I just wanted to let you know that before we get started. So maybe I'll just start with one question that your talk made me think about. I think sort of maybe halfway through or so, you started talking a little bit about the importance of rights to equal resources, I think was the phrase. And you used the phrase equal access to healthcare. And then, throughout the talk, you talked about all the intersecting ways, I think the phrase was intersecting forms of violence that you used that produce poor health outcomes among, in particular, Black people. But shifting back towards the equal access to healthcare concept, I was kind of curious to hear what your thoughts were about, for those of us in the medical care sector, right? And that's just one part of health, obviously, but those of us delivering medical care. What are the ways in which we can achieve not just equality, equity, and liberation within that sector? How do we, I guess what I'm trying to say is, how do we achieve a equal access to healthcare? What would that even look like?
It's a great question. I mean, and there's a number of ways to answer it. I think maybe focusing on process is better than focusing on destination, because one of the problems with how we distribute healthcare now is based on insurance, which, as we know, then tiers who receives care by your income level, and then has been shown to tier care by your racial and ethnic group, which I have been saying segregates our care. So I think one of the process mechanisms to increase access to healthcare across groups in this country who face hardship either because of their socioeconomic status or because of their racial or ethnic status, I think, is to eliminate health insurance as a barrier to that care. That said, I want to be clear that even if we got rid of health insurance, if you just dropped a pin right now on everywhere a health facility is located, right, not everybody lives proximate healthcare facilities, particularly folks who live in rural parts of the United States or folks who live in such dense urban centers that it's hard for folks to kind of access the care that may even be in their own backyard. And so then I think we then have to think about, well, then how would you redistribute where that care is located across the United States so that everybody lives within a convenient access of that care? And then we'd have to talk about what happens when people walk through that door or even walk up to the building. are the ways that we design even the facilities and the way we distribute or deliver, I guess, healthcare resources, are they really built around the populations that we serve? And one of my concerns, and um, the reason I bemoan our focus on trust, is that I think the focus on trust illustrates the ways that we aren't willing to build care around what people want. I'll give the example of the COVID vaccine, right? There's now all this concern about, well, what if Black folks don't get the COVID vaccine? Because Black folks have the lowest annual uptake of the seasonal flu vaccine. Black adults, Black children do a bit better. I think it's about 60%, but Black adults, it's like less than 50% get the annual flu. And so folks are like, we should be talking, and when I say folks, I'm talking about like actual messaging campaigns that are likely to roll out are right now considering language around trust. What we should do is increased trust. And what that tells me is that you then haven't acknowledged the completely accurate structural analysis that communities of color have about what happens when they come to receive our care. People don't feel safe. And so if we're going to build facilities that are really accessible when people get to the front door, we also have to ask ourselves, what allows people to feel safe in this facility? And one of those ways, among many, is police-free hospitals. Another is absolutely to also treat patients with dignity and care. But one of those is police-free hospital.
Wonderful, thank you for that response. So I'll give you another question that sort of combines maybe that combines a couple of the questions that I'm seeing here. Well, I guess let me actually start with this one. Maybe could you talk a little bit about medical education? Do you have any thoughts about ways in which institutionalized racism or some of the sort of violent concepts that you spoke about, some of the ways in which those might actually manifest in the way we educate physicians or the way we educate residents?
Absolutely. I mean, me and my colleagues in the New England Journal, one of our recommendations is that we actually make mastering, not just learning, not taking a training, but mastering the ways that racism affects health a professional competency. We should consider this a baseline of what it takes to be a clinician, and it should be embedded into board training, certifications. It should be embedded into licensing and accreditation requirements for facilities. Like, we have to make sure that clinicians understand these connections and are taught these connections in medical school and then through CME throughout our lifespan as clinicians, and then that we know how to apply it effectively. I think evidence abounds that we're not doing a good job at that. I think some of that evidence is how we write about racial health inequities in the literature, which is why colleagues and I tried to call that out. Like, how we write about that is telling that people don't actually understand how racism works. And then the other piece is, there was that data that I think it was from 2018, that study from a medical school in Virginia that basically found that, it was a small sample. I think it was maybe like 100 or 60 or so, but like half of the medical students and half of the residents also held all of these false beliefs about actual biological differences between racial and ethnic groups, and that it informed how they then determined how they would treat a patient's pain. Like, I think we have a long way to go. And I think that could start with us in medical school, but then obviously has to stretch even further back to just how we teach about history in school in general for kids.
You even saw some of that. I mean, that last point you made about the emphasis on genetic differences as explaining disparities. I mean, it was actually, disturbing during, and it remains disturbing during this pandemic. As these, huge inequities have come to light, the ones that you highlighted so powerfully, some people sort of use that actually to sort of make very regressive points to raise the question of whether some disparities, for instance, the fact that this began in China, could be explained by genetic differences. That was something I'm sure you have encountered or heard about, and certainly here in the United States, I think we've seen the disparities used by some to almost suggest that there's that this is the fault of certain communities. And so I guess my question is, how do we better ensure that by highlighting disparities, we show the injustice of it, and that isn't somehow hijacked by a reactionary agenda.
I love that you're saying this. I'm going to tie in a couple of the questions I see too, because we have a problem with blaming patients, and that we say that the reason we respond this way, first we say that the reason you have these outcomes is mostly your fault, which is some of what this thing of trust does. Like, you know, if only you trusted us more, probably we wouldn't have this outcome, which is just not true. And part of that fault finding, I think, extends into, there are some questions in here about, like, what about violence that happens in the hospital? Like, how are we going to get rid of the police if there's violence? Somebody even quoted like 70% of patients. Where is this one? This is from an ED physician who says, I will get statistics on violence in the workplace with 70% of RNs reporting being hit and kicked on the job. Another person asked about like community level violence. How can we get rid of police because of violence? So first, we have to acknowledge, one, that we are supposed to be a caring profession, right? We are supposed to be the ones that understand what happens to human beings when they're in crisis and how to de-escalate that crisis in a way that takes good care of them. And yet, instead of us employing the skills that we are given unique training around, when we fear violence, we also want to respond with violence by having security come. So first, I think we have to question the ways that we rely on violence in the same ways the rest of the community relies on violence, which is a little bit of a double talk, right? Because we shouldn't have community violence, but if you bring violence in the hospital, we're going to bring violence to you in the hospital, right? We got to own that. Second, I think to get around that, then we need to use the example from here in our county hospital in San Francisco. I think we need to start training our staff in de-escalation. I think I am not trying to minimize the concern that some patients are erratic and sometimes can try intentionally or unintentionally to hurt staff, nursing, physicians, anyone who comes across them. I am saying that if we want to endeavor to actually be a caring system, that we have to find a way to respond to that without responding with a threat of force and violence, which is what happens when we call security or when we try to restrain patients in physical ways. And if we can't do that, then the rest of society has no hope of doing it. They're looking to us to do it. And so we have to take that on. So I wouldn't say, when people talk about getting rid of police or police-free hospitals or defunding the police and I see somebody with a question that said, we should rebrand that. We shouldn't rebrand it. We have to help people come to understand what it really means, because it's not just a disappearing of police one day and nothing in its stead. It's talking about shifting what we prioritize and then building up the infrastructure and using the funding from policing to build the infrastructure to respond to conflicts, including violent conflict, in a different way, so that we don't blame patients, so that we don't say, oh, it's your fault the police had to come, you hit the nurse, right? And then if something bad happens and then, well, they hit the nurse, they got shot by the police in the hospital, but they hit the nurse. Like, no, we should have other ways of responding. And if we don't have that, again, I think, what hope does everyone else have?
Well, thank you for that. I guess we're just about out of time. It's just about 4:00 Eastern, and we've taken a lot of your time. But I wanted us to again echo, and I guess you're seeing it, just how many, how much it seems like everyone really appreciates this talk, and I know I did and learned a lot from it. And so thank you, Dr. Boyd, for joining us and for that really impressive presentation.
Oh, thank you so much. I'm so sorry we ran out of time for all these questions. They're incredible. Feel free to hit me up on Twitter and we can chat more. And I'll also share the slides with the organizers, which has links to all the references so you can read the original sources of all of the data.
Thank you, Dr. Boyd. Have a wonderful weekend, and thanks again for joining us.
Thanks. Bye.
Bye-bye.